Okay, good. I know the hour's getting late, and we have more sessions after this, but welcome to the Tricuspid session. This is Canyon 3. My name's Gaurav Alawati from the University of Michigan. My co-moderator is Percy Boateng from Mount Sinai, and there is supposed to be another moderator, Professor Ahmed Fouad, so if he comes, please come up to the podium. But we'll get started with the first speaker. Really needs no introduction to the Heart Valve Society. Dr. Maria Steiges is going to talk about the role of imaging, and she's been really leading the charge with tricuspid valve imaging.
Thank you, Gaurav. Okay, so the question is why we need really imaging to improve tricuspid regurgitation therapy, and why this imaging has to be multimodality. Mainly because it provides, as in all heart valve disease, complementary information on all the aspects of valve dysfunction. So quantification of the disease, the functional anatomy of the valve, which is essential to understand, and the hemodynamic impact of this valve dysfunction. This is crucial to understand what happens to the valve and understand the underlying mechanism and lesions there that are crucial to treat it properly. It's essential to guide the therapy in terms of timing intervention and delivery of the intervention, and finally, to check the results of the therapy. So we are going to focus on how imaging guides the therapy in the setting of tricuspid regurgitation. So regarding timing of intervention, this is what the European guidelines say, very similar to what the American guidelines say. And mainly the indication for intervention relies on the presence of symptoms, but also on the presence of a severe tricuspid regurgitation, on the presence of annular dilatation, and on the presence of right ventricular dilatation and dysfunction. The three last depend on imaging. Regarding quantification of TR, I'm not going into deep, but we recommend an integrative approach, as you know, and the definition of severe tricuspid regurgitation, which is the indication for intervention. It relies on different parameters, including vena contracta width, vena contracta area by 3D echo, the estimation of regurgitant orifice area, and also of regurgitant volume. But the most important thing is to keep an eye on tricuspid regurgitation and don't rely only on color Doppler. Why? Because we know, like in all valve regurgitation, this is a load dependent situation, but particularly in the right chambers where what we see on the color Doppler depends a lot on the loading conditions and on the status of the right ventricle contractility. And just as an example, this is exactly the same patient 5 minutes before anesthesia and when we went into anesthesia, and you can see how what you see with the color diminishes, and that can make you get confused on the amount of regurgitation this patient has. And this is why it's so important also to analyze the geometry of the tricuspid valve, and particularly the size of the annulus that we can measure that we typically measure with echo, with 2D echo on the septal to lateral dimension, but now can also be measured precisely with 3D echocardiography or other imaging modalities as CT or MR. Second aspect is the third aspect is the quantification of right ventricular function. And indeed, again, here we have an integrative approach. We have 3D echocardiography, we have strain echocardiography, but we also have other imaging techniques, and mainly cardiac magnetic resonance, which is our gold standard. If there is a gold standard, this is the role of magnetic resonance in measuring right ventricular volumes and ejection fraction. We know what's normal right ventricles, but currently we don't know exactly what are the thresholds for for indicating tricuspid intervention. We are getting more data on that, and in this sense, this is a work from Mayo Clinic proposing 2 thresholds for intervention according to right ventricular free wall strain, longitudinal strain, and also to the regurgitant volume of the tricuspid, the tricuspid regurgitant volume. particularly strain seems interesting, but still we need more data on the reproducibility, of course, of these thresholds that are a guide for our timing of intervention. Another interesting parameter that will be further developed on is the ratio of the TAPSE and pulmonary artery pressure estimation or determination. This is a surrogate for the coupling of the right ventricular, so the relationship between the right ventricular contractility and the pressure in the pulmonary artery and it seems that this could be also a good parameter, less load dependent than ejection fraction or others in these surrogates of myocardial contractility that we currently use. The idea is to find the right spot and going there in that spot where the disease is not so advanced and that the intervention might be futile. And this is also important because this also determines, together with the concomitant comorbidities of these patients, the type of therapy that we are going to apply. Because fortunately, currently we have many options for these patients that usually are elderly patients, or at least in developed countries, they are usually elderly patients. They are advanced stages when they come to us. So fortunately, we have many options. So we can have surgery, we can have transcatheter. So mainly at this time of our current knowledge, what determines if we go for a transcatheter or surgery is mainly the frailty or the comorbidity, the surgical risk of these patients. But it's also, when we decide which type of intervention, if it is repair, replacement in surgery, or if it is repair or replacement in transcatheter field, we need to really understand what's happening to the valve and the underlying mechanism and the anatomy of the valve. And for that, echocardiography is still, and particularly transesophageal echocardiography, is still the most used technique and the most useful technique. So from there, we can understand the underlying dysfunction of the valve, if it is annular dilatation only, if it is prolapse of the valve, if it is restriction of the leaflets, and which type of restriction. And even in 90% of the tricuspid regurgitations we see at least in the US and in Europe, which is secondary TR, secondary to right ventricular or right atrium dilatation and dysfunction, we need to understand in which stage of the evolution is this tricuspid regurgitation, because this is a progressive disease that goes from coaptation of the leaflets, as you can see, as you can see there. So where the leaflets coapt, and with progressive dilatation of the annulus and the ventricle and the atria, this surface of coaptation is completely eliminated until very advanced stages of the disease where there is also leaflet retraction and tethering due to ventricular dilatation. So it's important to understand that, because at some intermediate state we can still repair the valve, and this happens in surgery and also in transcatheter. But if we go to more advanced stages, we should go for replacement. And this was already established for surgical techniques, but it's the same for transcatheter diseases. So this was a proposal on some thresholds on the height of the tethering of the leaflets in tricuspid, where the surgeon should replace the valve because annuloplasty alone was probably not enough in the long-term run to make the valve competent again. So the same rationale happens. Oh, something weird happened here. The same rationale happens in transcatheter therapies. Another entity that we are dealing more and more, because we are using more and more intracardiac electrodes, is the presence of tricuspid regurgitation associated with the presence of leads. And here again, imaging is crucial to understand the relationship between the lead and the induction of tricuspid regurgitation. So as you can see here, this is a transgastric view, short axis view of the tricuspid valve, and you can see that the pacemaker is there in the posteroseptal commissure and has nothing to do with the tricuspid regurgitation, which is in the anteroseptal commissure. While the image on the right of the screen, you have same view, but you can see that the lead is impinging on the septal leaflet and inducing there the tricuspid regurgitation. Understanding all these things is really crucial to, once we have decided if that's a surgical or a transcatheter candidate, to select which is the best therapy for that particular patient. And that's the algorithm proposed by the tricuspid focus group from PCR in Europe, but mainly is the idea of if you have a smaller coaptation defects or gaps in the tricuspid, you can go for edge-to-edge or maybe annuloplasty, while if you have a more deformed valve with larger gaps, larger surfaces of uncoaptation, then you should go for either orthotopic or heterotopic replacement. How do we measure these gaps or this loss of coaptation? Again, with echocardiography, and particularly with 3D echocardiography, we can do multiplanar reconstructions, cutting exactly where the gap is and measuring it precisely. Another important aspect is the anatomy of the tricuspid valve, particularly for transcatheter therapies and mainly for edge-to-edge repair. Why? Because you can imagine these are 5 different tricuspid valves, which is only 40% of the cases, as you surgeons know a lot, really tricuspid. Many of the tricuspid valves have more than 3 leaflets, and they have a lot of indentations. And of course, if you're planning to put a clip there or a device, and if you have no tissue, that's impossible. So understanding this anatomy is crucial on our strategy. And this is on our strategy when we are dealing with transcatheter edge-to-edge repair. So this is why we can classify a little bit according to the anatomy and the functional anatomy, what are the ideal valves for edge-to-edge, or the ones who are very difficult to undergo this therapy. And this is another demonstration of why imaging is crucial to really understand the valve, but also to select the best therapy. And as you know, one image is better than 1,000 words. These are 2 different tricuspid valves. On the left panel, you have a real tricuspid valve with a relatively okay gap that you can see very central, clear. On the other right side, you have a 4-leaflet tricuspid valve with a much larger gap. So the one on the left, easy to clear, or easy for TR edge-to-edge. The one on the right, really challenging. Finally, other therapies, mainly annuloplasty, percutaneous annuloplasty, and orthotopic and heterotopic replacement. They need CT always. Why? Because we need precise measurement of the sizing of the annulus. This can also help in the access, depending on how the vena cava, the inferior vena cava goes into the right atrium, and also for the sizing for heterotopic valves bicaval systems. So importance also of the multimodality imaging. Indeed, in our institution, every single patient that comes, because we are doing also percutaneous annuloplasty, every single patient that we approach for a transcatheter therapy, we do CT plus transesophageal echocardiography. So to sum up, imaging provides crucial information for guiding timing and type of intervention. Of course, essential to see that we have severe tricuspid regurgitation without advanced right ventricular dysfunction, with long, flexible, and not tethered leaflets if we are thinking of repair, without excessive annular enlargement, because then we will have tethering and not, and we will go for replacement. And of course, multimodality imaging provides all this information. Thank you very much for your attention.
So Marta, I'm going to worry that the discussion will get short, so if there's any burning questions, please ask Marta. But I do have one question to start, and that is, when is the ideal time to image? You know, we know that there's so much variability. You even showed a beautiful characterization of that under anesthesia. And the number of patients that we are referred oftentimes that aren't even on a diuretic because somebody says they don't have edema. And so nobody's put them on. Give us your thoughts on how do you, in your center, how do you identify when's the best time? Do you do a right heart cath first before you really look at the echo? How do you optimize them? How do you know when's the right time?
Well, the first thing is to look at the tricuspid valve when we intervene the mitral, first thing. That's the very first thing, because if we do things at the right time, probably we don't go for late referral. So that's number one. Number two, when we are suspecting tricuspid regurgitation, I think we should evaluate the patient. I mean, symptoms are difficult to rely on. And we should really scan the patient with the regular conditions. If we scan the patient after optimization of the therapy, of the diuretic therapy, we are going to be really unblinding the thing. No? And the other thing is always we tell our residents and our fellows to measure the annulus, look at the annulus, and measure at the coaptation, because you may see very small color Doppler if the patient has diuretics, but if you see that the tips are just not touching, or almost not touching, I mean, then you have to suspect more TR. What to do then? Probably something like leg lifting or something that maybe hand grip, we don't know hand grip, but left lifting, whatever, may help. So I think we should be more proactive, really, and suspecting it earlier and looking more at the annulus and the surface of coaptation. Yeah.
All right, any other questions? Thank you so much, Marta. That was enlightening and important for all of us to hear. Thank you.
All right, I'd like to introduce Dr. Kang to tell us about the role of right ventricular pulmonary artery coupling as a predictor in isolated and combined tricuspid valve surgery.
Yes. That's next. Thank you for the opportunity to present our study on the role of right ventricular pulmonary artery coupling as a predictor in isolated and combined tricuspid valve surgery. RVPA coupling describes the relationship between RV contractility in relation to the afterload of the right ventricle. It means that low RVPA coupling ratios indicate that the RV has a poor contractile response to an increased afterload. Echocardiographic measurements are used as a surrogate for invasively measured RVPA coupling ratios acquired by PV loops during right heart catheterization. There is a lack in practical predictive variables for the post-operative RV contractile function assessment. And therefore, our study aimed to analyze whether RVPA coupling is a factor in predicting outcomes in patients undergoing tricuspid valve surgery. Our study is a retrospective single-center analysis where we included patients who underwent either isolated or combined tricuspid valve surgery between 2013 and 2024 and had a sufficient pre- and post-operative imaging. RVPA coupling was calculated by dividing the TAPSE with the pulmonary artery systolic pressure, and our primary outcome was all-cause mortality. Secondary outcomes were in-hospital outcomes as mortality, ICU and hospital stay, and the prolonged use of inotropes post-operatively. Here are two exemplary patients of our cohort. On the left side is a patient with poor, on the left side it's a patient with poor RV function. He has a low RVPA coupling ratio of 0.12. On the right side is a patient with good RV function, high RVPA coupling ratio of 0.65. We used spline curves because the relationship is nonlinear to assess the optimal cutoff value for RVPA coupling in our cohort, which was 0.339. Looking at the baseline characteristics, they are mostly similar, 67 years of age, approximately half of the patients male. and the SDS score was around 5. There was more patients with diabetes in the and a lower GFR in the low RVPA group. Looking at the survival, the patients with lower RVPA coupling ratios had a poorer 5-year survival of 72.5%, and all in-hospital outcomes were worse in the low RVPA groups. We wanted to assess whether other parameters of RV function are also predictive in our cohort, and when adjusting for ejection fraction, preoperative atrial fibrillation, diabetes, and GFR, only RVPA coupling ratios had a predictive value in the Cox regression model. So in conclusion, echo-derived RVPA coupling is a powerful marker to predict early and midterm outcomes in patients undergoing combined mitral and tricuspid surgery. Higher RVPA coupling ratios are associated with lower all-cause mortality, and in our study, RVPA coupling is a better predictor than isolated RV function parameters. But further analysis are required to validate the optimal cutoff values and to see if which cutoff value is best to predict outcomes in this patient cohort. Thank you.
I just want one question. Since this is sort of fairly new, has it changed your practice at all in your hospital based on this information, or you guys are just waiting for a larger study to do any change in your practice, clinical impact of your finding?
So I think it could help in assessing which patients are at higher risk of adverse events during the hospital stay. In addition, because I mean, in the last years with TriScore and also some groups studied MELT 11 scores to assess outcomes in those patients, maybe that can be an additive to these risk models, that we have a better understanding whose right ventricle are going to do better after surgery.
Yeah, I think it's important that there's several risk models now. Many of them do not include RV function. The TriScore does, so that's somewhat helpful. And I think we're seeing more and more literature with this, particularly in the transcatheter space. I did have a follow-up question, but Sergey, you want to respond?
Yeah.
Sergey is
yes.
the senior author on this paper.
Yeah, thank you. Great presentation. If I may add, so progressive TR leads to RV dysfunction, volume overload, and by doing intervention, we stop this natural history. But we don't have very good predictors seeing how right ventricle is going to deal with the afterload after the surgery, after we fix that. And so this is a brand new, kind of brand new, but very powerful, very distinct predictor showing how this nonlinear relationship between the RV work and the afterload interrelates to each other. And the TAPSE or RV strain alone is not enough because it's such a complex nonlinear relationship. So it hasn't changed our practice yet, but we are going to do more and more research into this, and I think it will. Thank you.
So one thing, and Sergey, this is a question for you, is also, I mean, many of us, can get pretty aggressive in our phases of our career on tricuspid repair, and one thing we notice is that we impact TAPSE post-op. You can essentially wipe out a lot of TAPSE when you're putting an annuloplasty ring, particularly if it's a semi-rigid ring. And so, I'm curious if you look, sounds like you're looking post-op as well.
We will. This is only pre.
And then, so then the other question is, you did a lot of repairs. We do see that some repairs end up failing over time. Is there any correlation with this ratio with ultimate success and failure late, let's say 1 year or 3 years or 5 years?
Interesting question. We'll look into that. Thank you.
Great, thank you.
Now I like to invite Dr. Karim Tariq from Nasser Institute, the presentation about isolated tricuspid surgery, 25 years experience of a single center.
Thank you so much for the opportunity to share this, our experience. It will be about the isolated tricuspid surgery, 25 years experience of a single center. As a start, all of us know the causes of the tricuspid valve disease is as primary causes accounts for 25% or secondary causes, which is 75%. But mainly what we see in our population is the rheumatic affection and the pulmonary hypertension due to a left-sided valvular heart disease. Here we're going to share our experience in the database. We have operated in the last 25 years more than 46,000 patients, of whom the isolated tricuspid patients were 305 cases. And here is the demographic data of these patients. If we found in these cases the tricuspid valve pathology was mainly functional in 31% of the patient and rheumatic in 28% of the patient, and the rest has failed previous repair or prosthetic valve failure or congenital or endocarditis. As the hemodynamic pathology of these valves, mainly 92% were regurg and 4% were stenosis and 4% were mixed. As the procedure has done for these patients, 58% were tricuspid valve replacement, 39% were repair without a ring, and 3% were repair with a ring. The valves implanted in these patients, 86% were biological and 14% were mechanical valves. Here are the demographic data preoperatively that we found that had no significant impact on our hospital mortality. As for these 5 factors, we did see that these preoperative demographic data predicted the mortality as the age, the diabetes, the redo surgery, right heart failure, or previous balloon mitral. When we put all these factors into binomial logistic regression, we found that the older age was the first predictor of mortality, followed by the presence of a right-sided heart failure. As here is the mortality for the effect of the tricuspid pathology on the mortality in these cases, we have found that in the ischemic it was 50%, in the failed previous repair 50%, in the prosthetic valve failure it was 14.3%, in the congenital it was 8%, in the endocarditis 7%, in the functional 12.8%, and in the rheumatic 15.1%. These are the operative factor predictors of the mortality. We have found that the most significant was the bypass time and the cross-clamp time mainly were found in the operative factor that predicted the mortality for these patients. As here's the results for the 305 cases with a total mortality of 13.1%, total of 40 cases. The main things were the low cardiac output, also as the neurological complications were found in this patient were significant, and the hours ventilated for these patients. So in conclusion, what we see is that the isolated tricuspid surgery is a rare valvular procedure and represents only 1.9% of all the valvular procedures we performed in our institution in the last 25 years, and it carries a very high risk mortality, 13.1%. And we found that the main pathologies are either functional, 30.8%, or rheumatic affection, 28.2%. And using the binomial logistic regression, the older age, the presence of the preoperative heart failure were the only preoperative predictors of mortality in this subgroup of patients. Thank you.
Thank you very much for this presentation. I have 2 questions for you. The first is regarding the group of patients who had heart failure before surgery. What was your protocol in terms of preparation, timing?
Say again, I can't hear you.
The first question is, you have a subgroup of patients who had heart failure before surgery.
Yes.
So what was your protocol regarding those patients in terms of preoperative adjustment, timing of surgery? And the second question is about the patients who received the mechanical valves. So can you comment on this, why you choose to put mechanical valve?
First question, usually the patients with the right-sided heart failure, or we get this patient preoperatively and we stayed in the ICU. We start them on milrinone infusion, we start them on Lasix, and we try to compensate them medically as the optimum, so then we can go and proceed with the surgery. And most of the time they come out after surgery also still on Primacore, and sometimes of this patient also we leave them open chest for a bit of a time until things resolve. So that's for this first question. Second question, for the mechanical valves, usually some of our surgeons do prefer if the patient had previously done a mechanical valve, So they don't mind putting also a tricuspid valve replacement with a mechanical valve. And also some of our patients, we do not have the luxury of finding a lot of biological valves. So we had to replace them with mechanical valves. So if we had a patient like he did like a double valve replacement with a mechanical valve, and then he came after that with a tricuspid valve and both valves are functioning, so we don't mind putting a mechanical valve in the tricuspid. Hopefully I know that sometimes think about the patient needed a pacemaker or something like that, so we had to put some patients epicardial leads after that, and yeah, hopefully I think went well.
I think this question about mechanical and bioprosthetic is really fascinating because we see practices are very different across the world. And so I was struck by how many mechanical valves, and it sounds like there's multiple reasons that you have. And let me ask, maybe before I ask you a question, in the audience, what is your preferred tricuspid replacement? If you say more often mechanical at your center, more often bioprosthetic, so majority of bioprosthetic. So, you know, it may be an access issue. Have been some literature recently. Korea had a national study that it was about 50-50, and they showed long-term benefit to mechanical valves in the tricuspid position. You look at North America, and they're hardly ever used. So maybe can you shed any insight about longer-term data in the mechanical tricuspid population? What do you run the INRs? Are you seeing any impact, thrombosis, pulmonary embolisms, anything like that?
Actually, no.
How is your follow-up?
We like to target the INR around 3.5. So actually, for me, I haven't seen any patient who came with a stuck or failed prosthetic valve in the tricuspid. Actually, I haven't seen.
Of the practice of prepping these patients with Primacor, is this something of a more recent, because this is a 25-year experience, I'm just wondering, 20 years ago, were you doing that, and were you doing more mechanicals earlier, are you doing less now? Is any temporal relationship?
Right now I think we're doing, for some political reasons, we're doing more mechanical valves in the tricuspid, as we have an issue with the biological valves here, actually, yes. You know, some of the companies are not all available here for us. And the patients are very symptomatic. We have a lot of patients in our waiting list line. They need an intervention in the tricuspid. So actually, we do more often now in our center, as I'm speaking, the tricuspid replacement with a mechanical valve.
Yeah, great presentation. I think the data is more like historic data, because if you look historically, the tricuspid isolated surgery carried a mortality rate sometimes up to 25-30%. Now, what is happening up to date with, as Percy is doing, he's doing a lot of these cases at Mount Sinai, you have to aggressively optimize this patient in terms of volume status, inotropy. Using Marinone is an ideal drug for this patient, also maintaining AV synchrony. We never take these patients unless we do a right heart cath to make sure they are hemodynamically optimized. The surgery is usually done on a beating heart to avoid right ventricular dysfunction, and we almost 100% of time using tissue valves, because if you have access for valve in valve, then the degeneration doesn't become an issue in the future. We never leave any pacing wires across a tricuspid valve, whether you repair it or replace it, especially if you're doing primary tricuspid, because you have to protect that repair by using either a leadless pacemaker or epicardial basing, because a lot of these patients will require basing in the future. We don't even hesitate to use biventricular basing sometimes to avoid pacemaker syndrome. This is just a general, you know, how we do it. And if you do that and you properly select the patient, the mortality will go down to 2 to 3%. I believe that would be, when we looked at Mount Sinai numbers, that's how it usually ends. So you can provide it, I guess, with relatively low risk still in reference centers.
Okay.
Thank you very much.
Thank
Great
you.
discussion. All right, our next talk is Dr. Kim, going to speak about the genesis of the unseen, the dawn of an unprecedented surgical tricuspid valve.
Sure. Thank you very, very much. Kim is my team member. My name is Faizes. I'm very much honored, and thank you for the invite. And on behalf of a group from the National University of Singapore, I'm going to talk about a novel tricuspid surgical prosthesis. So, okay, at present, if we look at to the commercial prosthesis, there is no commercially available surgical tricuspid valve prosthesis in the market, which is actually compelling the surgeons to use the mitral valve prosthesis as a substitute. We here developed and evaluated preclinically a dedicated surgical tricuspid valve. And the key feature of this valve, I'm going to show you in a minute, is closely replicates the natural anatomy and function of the native valve. So the novel tricuspid valve prosthesis features 3 flexible bovine pericardium leaflets, an adaptable asymmetric 3D ring, and it features cord that mimics those of the native valve. So the picture from the left to the right is showing the CAD design. It has 3 leaflets, and all 3 leaflets featuring the cords are bundled together, forming a cord cap. And in the middle, you can see the structure ring, which is somehow classic, and the last one was the prototype. So we evaluated these particular processes in vitro setting with compliance with the ISO 5840, and have done the ex vivo porcine heart experiments, as well as the acute animal studies, 4 porcine and 1 ovine study. And we evaluated and implanted it in 2 cadavers, and followed by a chronic ovine study just completed very recently. As given the time limit, I'm not gonna describe all these. Let me touch base the most important key points, how we implanted this device into the recipients. We have evaluated the recipients with CT imaging before the procedures, and 3 key important parameters was the tricuspid annulus dimension, and finding out the most prominent, which is the anterior papillary muscle, and how its anatomy was. And to determine the device length, we had to measure the distance between the annulus and the anterior papillary muscle. Following implantation, this is a postoperative echo images, transesophageal echo, as you can appreciate on the left, which is the 2D. You can see the cords that featuring from the device, just replicating and looking like, which is biomimicking, I must say. In one case, however, we have done a fluoroscopy just to understand that how this device is performing. So here you can see an radiography and as well as an RV-graphy. The device, the ring is appreciated, and the device was functioning properly. And after an acute implantation, we have done a necropsy, and as you can appreciate, the cord is very much attached to the most prominent, the anterior papillary muscle. To summarize our result, in the in vitro testing, we found the effective orifice area for a size of 33. The effective orifice area was about 2.8 centimeters square, with an acceptable pressure gradient and an acceptable regurgitant fraction. In an ex vivo beating heart, following the transplant principle in a porcine study, we could visually confirm the proper caudal attachment and the leaflet function in that recipient. And we have, as I said, that we have done 4 porcine studies, which were acute, that demonstrate the feasibility with good anatomical fit of the prosthesis. And in 1 ovine study, I have just shown you the fluoroscopy. And lastly, the chronic animal study literally finished yesterday and showed the 90 days survival of all 3 recipients. So in conclusion, I would like to say that this device demonstrates the successful implantation of a novel surgical tricuspid valve prosthesis. These innovative surgical tricuspid valve prosthesis could greatly enhance the patient outcome, but of course, it addressed the current technology limitation and requires the first-in-man human studies to confirm the preclinical results and ensure the long-term benefits of this particular device. Thank you for your attention.
That's fantastic and very interesting, and maybe want to just make a comment and then a question. First, everybody should be aware that none of the bioprosthetic valves that we use in the tricuspid position are actually approved for them. They're all mitral valves, and so in the U.S., for example, there is none of these valves are, quote, approved. So maybe you can just take a step back. How do you foresee this, one, as a benefit, and number two, to study it? Because, for example, in the United States, the reason is the number of tricuspid valve replacements is quite low. For a company to get approval, it's quite challenging to enroll those patients. So maybe those two questions.
Thank you so much. This is a very interesting and compelling question. We look back into the history. The history of the heart valve development started back in 1960s, and the company, for the commercial reasons and the patient population, they started building the aortic valve only. And if we look into the mitral valve replacement history, we see that the aortic valve was actually used reversely in the mitral position. There was only one available prosthesis for the whole spectrum of the aortic and mitral pathologies. And as we all know, tricuspid is a forgotten valve. At this moment, we're looking into the different registry, and yes, I agree with you, the volume is pretty low, as because we are not addressing and finding out the appropriate population. They actually need the tricuspid intervention. So we looked into multiple registries, including the STS database. Even the isolated tricuspid valve replacement numbers are growing significantly. So we believe until when we will finish developing this device, the number of patients needing help with tricuspid replacement will be pretty good, pretty large.
Can I just one quick question? Why the need for the cord attachment to the papillary muscle? I mean, in most, bovine valves and other things, there's no need to attach anything. They're all tri-leaflet, and they close on pressure. So
we preserve all the cords.
We preserve, yeah. So.
Correct. That's another very interesting question. So looking into the atrioventricular valve compared to the aortic and pulmonary valve, the native valve feature cords. And why there is a necessity of the cords. The necessity of the cords is not to maintain the functionality of your device to open and close. That's not the major function. The major function that we believe is still subject to proof, that it should prevent the overdistension and a failing ventricle. So if you cut out all the cords, there are multiple studies being done for mitral position for the need of the cord. Why? The repair became gold standard because it is preserving the native structure. So we believe preservation of the native structure, or at least if you preserve the most important components, because there is no way we can replicate all the cords that's natively designed. At least we need to provide some so that the major function being preserved. So the principle says if you preserve the cord, there is an annulopapillary continuation, which will prevent the dilatation of the ventricle and prevent heart failure in long run.
So just to clarify, in your practice, and maybe rheumatic patients are different, are you excising the tricuspid valve to do a replacement? Like I think in the North American practice, we just put the valve right inside and preserve the entire valve. Perhaps there might be a rare patient that has some thickened cords because we don't have a large rheumatic burden, but maybe just describe that.
Definitely. So it depends on what kind of pathology the patient is suffering from and where the patient being referred. So if it is the gold standard is we still go for the repair for tricuspid regurgitation, and definitely for the rheumatic population, we remove everything, excise the whole valve and replace.
Thank you.
Thank you so much.
Well, our next speaker does not need any introduction. This Gaurav as well know him. He's going to tell us about TEER and TVR surgery and where the chips fall in 10 years.
Okay, great. So I was asked to talk about maybe predicting the future with tricuspid valve theory, what's going to look like in 10 years. I am involved in a number of different surgical and tricuspid transcatheter trials, so those are my disclosures. So a few points that I'm going to bring out. The first is traditionally, we've been told, and our own data has suggested from national registries, that isolated tricuspid surgery has a high morbidity and mortality. And really for this talk, by the way, I'm going to focus on isolated disease. And we have to emphasize a lot of the studies we've heard, it's combined. And I would argue that in the US, we've shown that you can perform concomitant tricuspid surgery with pretty low morbidity. It's the isolated patients have a very different profile and a lot more RV dysfunction. So what is the data now for morbidity and mortality? If we look at the most recent publication from the Society for Thoracic Surgeons, this is last year's data, the operative mortality for all isolated tricuspid surgery has decreased to 5.6%. And it's really no different whether you repair or replace the valve. You can see there are other important complications that we worry about, reoperation typically for bleeding, renal failure, which is a big risk, and for many of these patients, they already have predisposition, and stroke is not that common. Second point, as we talk about the transcatheter approaches, and there are now 2 approaches that have been approved in the United States, and they are already in practice, many of them in Europe as well. Tricuspid TEER is very safe, and in many cases it can reduce tricuspid regurgitation. So I'm going to share just a little bit of data. In North America, this device, TriClip, is approved. Also in Europe, there are more than one device. And this is a device that's basically a mitral TEER-like device that's been modified in terms of the delivery system to be able to put it on the tricuspid position. And so the knobs are a little different. The steering is a bit easier using this device compared to the original MitraClip system. This has already been published in multiple studies, and I'll just share a couple highlights. First is the safety profile. You can see it's a very safe procedure. 0.6% procedural mortality, very low mortality. Cardiovascular mortality, endocarditis is low, new onset renal failure. You can see risk of bleeding, all these things are very low. So overall, it's a very safe procedure. What do we see in terms of the efficacy? And if we look at the efficacy in terms of reduction in tricuspid valve, it can work. So about 3/4 of patients have an improvement in their tricuspid regurgitation. Probably depends a little bit on what we call that bar. The majority of them may end up with moderate tricuspid regurgitation. I know Marta alluded a little bit to some of the severity, and there's many new scales that people are using, and you can go from torrential to severe, and it would still be called a trial success. What that means for the patient, we don't quite understand. And when we look in more and more detail out to 2 years, this remains consistent. We're not seeing more and more patients necessarily progressing, but it's not consistent to always get this type of result. It's very difficult. But in the right patient, you can see a good result. How we pick this is a real challenge for all the heart teams. How do you go from a severely leaking tricuspid valve to really what looks like a surgical result? That is not, unfortunately, always the case. Point number 3, tricuspid replacement, the Evoke valve, which is now approved again in the United States, predictably eliminates TR. So different from the TEER devices, we can reliably, nearly 100% of the time, eliminate tricuspid regurgitation. However, there are some costs. It's not as low risk as tricuspid TEER, and there's a risk of pacemaker and risk of bleeding. So this is the device we're talking about that's approved in the United States. It's a 28 French device, so it's very low profile. It can go in through the femoral vein, no cut down needed. There's now multiple sizes, 4 sizes, so these very large valves can be treated. What that means for the ventricle is still a question mark. And this is some of the outcomes. The mortality with the procedure at 30 days is 3%, so not as low as the 0.5%. Now you compare that to medical therapy, of course there's no mortality. Out to 1 year, the mortality is about 8%. That's just showing the 6% difference, 8 to 9%. So it's not a completely benign procedure when it comes to mortality. You can see bleeding is common, happened in 10% of patients, typically either access site bleeding or more commonly GI bleeding. These patients all end up on anticoagulation. Many of them have AFib already, but for some reason when you put this valve in, there seems to be more precipitation either from the stress of the procedure, and so there's more bleeding. And then most importantly, the last line is implantation of a pacemaker. See, as high as 25%, so fairly high chance of a pacemaker. Mind you, about 20% of the patients in the original trial already had a pacemaker. So pacemaker is one of the costs for this device. However, on the flip side, 99% of patients have moderate or less TR, and 95% have really no meaningful TR. So much different from TR, you can really get a great result. Next point, how we predict the future. There's a ton of industry investment in transcatheter solutions, and how much is there investment in surgical devices from these same companies? Almost none. This is just a snapshot of some of the devices that are being developed, and I won't go into all these in detail, but there's multiple approaches from annuloplasty devices. Some have been in various stages of evolution. Some have been taken off the market, redesigned, put back on the market. Coaptation enhancement, so things like TEER devices, replacement. There's a whole page, probably 5 times the number of companies that are working on tricuspid replacement, both in situ as well as heterotopic, so putting it in the IVC and SVC, as well as some type of spacer that enhances coaptation, like a Forma device or TriFlow device. The next point, I think Marta shared one slide on this, who are the patients that are candidates for isolated tricuspid surgery? I think Ahmed's going to talk a little bit more, Dennis is going to talk a little bit more about that as well. If we look at the guidelines, tricuspid surgery really for isolated disease is quite uncommon. There isn't a lot of patients that have there's certainly no class 1 indication, mostly class 2A for patients with primary MR or if they have left-sided surgery. So isolated tricuspid surgery doesn't have strong guidelines, and that's really our fault as surgeons. So I try to, unfortunately, this is somewhat a bleak picture with all this investment, 2 devices in the United States that are approved, one for repair, one for replacement. They're both safe. Is there hope for surgery? And I think there is, yes, and I think we're hearing that centers are developing better experience in terms of selecting patients, optimizing them. This is a paper that's in submission. We looked at 3 different eras, and the most recent era at our university in 2021, we've had no mortality for isolated tricuspid surgery. And the morbidity is very low, 9%. So we can absolutely improve with good patient selection, more thoughtful techniques. And this paper actually just was published, or was accepted this week, looking at tricuspid replacement. Generally, most studies show tricuspid replacement has a higher mortality. Those are more advanced patients. And we can also perform this with improving mortality, morbidity, and that's with more experience in optimizing patients. So there is not good data comparing transcatheter approaches to surgery. And none of the trials that have led to approval for tricuspid TEER or for tricuspid transcatheter replacement included a surgical arm. They were all patients that were deemed higher risk from the team. This is probably the closest that I can find. This is from Julius Dreyfus, who is leading the TriScore registry data. And what I want to share with you from this data, if we look at low-risk patients getting surgery versus transcatheter, although they didn't compare them statistically, you could see that there likely is maybe a signal that there's better outcomes with surgery in low-risk patients, and that's also true in intermediate-risk patients. Once you get to high-risk patients, and I won't go into the details with the TriScore calculator, it's actually an app, so everybody can download the app, just put in TriScore, and it takes about 30 seconds when you're seeing a patient to develop a risk calculator. You have a better idea of what's that patient's surgical risk. And a high-risk patient, there probably is no benefit to surgery or transcatheter. Maybe they should just get medical therapy. So who are the patients now that we end up operating on? So this was a 78-year-old female that developed an injury to her papillary muscle after a microinsertion. So micro is a leadless device done through a 28 French sheath through the groin. And unfortunately, you can see in the left upper area, you can see that there's the micro device, and it actually had torn the entire tricuspid valve apparatus. And unfortunately, she was not a candidate for transcatheter approaches based on the anatomy, a very big annulus. And you can see that these are the patients that we're seeing surgically were first thinking about transcatheter approaches, and if they don't have an option, then we're taking them to surgery. And in this patient with a lot of leaflet, we're able to repair the valve and have a good result. But this is a very uncommon thing that we're seeing. Most of the patients are getting transcatheter approaches. And then here you can see this was done. I think there's some comments about how to do the procedure. There's theoretic benefits to doing beating heart. Maybe you can get a better assessment. Maybe you can tell if there's any injury to the AV node. But regardless, there's many ways to do it. We elect to do these through a minimally invasive approach to try to minimize bleeding and through a beating heart. The other group of patients we're going to start seeing more are those that had transcatheter attempts and they failed. So this was early on in our tricuspid experience, before there was any study. A patient that we really did not want to operate on, who has ascites and chronic hypotension on dialysis. In my mind, if you have a patient on dialysis that's hypotensive at baseline, they need midodrine in order to get through dialysis. They're pretty sick. And you could see we were unsuccessful in placing the clip between the anterior and septal, and the patient ultimately needed surgery. Fortunately, we were able to do it, a repair, but long term, I do not expect this patient to do well. So in conclusion, 10 years from now, transcatheter devices will overtake surgery, just like we've seen for TAVR, and we're starting to see for mitral, especially for isolated tricuspid disease. This is a plea for surgeons to stay involved and help select these patients, help do the procedures. These transcatheter devices have a better safety profile, even without better efficacy. The guidelines for surgery remain limited, and I don't expect that to change a lot because we haven't done true randomized trials, and the gates are now open for transcatheter approaches. So my prediction in the future, unfortunately, is that it's always going to be a transcatheter approach first strategy, and surgery will end up being reserved for rejects or failures, and that's our future. But don't be disheartened because we can remain involved. Obviously, concomitant surgery I mentioned is very different, so we're really talking about isolated tricuspid surgery. Thank you.
I guess the question I have is, do you think there'll be sort of the creep towards identifying patients with TR early and earlier once the general cardiology community accepts that maybe it's safer to do TR, just like we're seeing in TAVR now, where they're doing asymptomatic severe AS and low-risk severe AS TAVR trials and predicting that there's a better survival if you do it earlier. So I think one of the Achilles heels of tricuspid disease is because traditionally, like I said, it was a forgotten valve, and it was a self-fulfilling prophecy. It's a high-risk surgery, so wait till they really need it. And by the time they come to see you, they decompensated, renal failure, liver failure, and it fulfills the prophecy. You're going to have a bad outcome. But
yeah, and that's been the issue. And I think Marta mentioned, these patients don't have symptoms. Like, what do they feel? They feel tired, and everybody feels tired. And so is it the tricuspid valve? And when they actually develop real symptoms, the RV is already too gone. And so at least the one benefit is we're getting these patients earlier. And in fact, that's part of the reason we've seen an increase in the number of patients we're operating on. However, with now 2 approved devices, we're seeing that's probably going to ebb back a little bit. So that's a great point.
And now moving to the next presentation, the title is Short Guideline Recommendations for the Management of Tricuspid Regurgitation Change by Dr. Denis Pochard.
Yeah. Hello, everybody. I'm Denis Pochard. I'm a mitral and tricuspid surgeon, and I'm as well quite a bit involved in mitral and tricuspid transcutaneous procedures. It looks like the session so far has sort of set the stage perfectly well to go ahead and discuss whether the recommendations for the management of tricuspid regurgitation should change over time. I find that paper that quite precisely described when should we change the guidelines, and I thought it was quite interesting, and a lot of it applies to us. So in first line, changes of evidence on the existing benefit or arms of interventions, and I will talk a bit about that when we discuss now a risk score. Changes in the available interventions, well, in our world, now the whole transcutaneous field is sort of new and needs to be categorized and have some recommendations associated with that. Changes in outcomes are considered important, but there's also that goes hand in hand with what's happening in the transcutaneous field, because that seems to be playing quite a bit negatively in terms of perfect echo outcomes, but quite positively in terms of morbidity and mortality of those procedures. So let's start by what are the recommendations, right? So just to put you in the swing of things now, what we design as stage C and D would be severe TR, either asymptomatic or symptomatic, but these are all patients with EROs above 0.40 centimeter. So the AHA recommendations out of 2020 says obviously severe TR, no, stage C and D, that are undergoing now left-sided stage, which is easy. Then the 2A indications, now we would have the typical moderate left-sided patients coming with moderate TR and or an enlarged annulus around 40. In the same way, patients with signs and symptoms of right-sided heart failure, severe primary TR, and are coming for isolated tricuspid surgery. So these would be also for primary TR, type 2A considerations. And for same type of patients with right-sided heart failure and severe isolated secondary TR with no attribute, where the annular dilatations would be present and poor medical therapeutical response, stage D. If we bring the indications further along to asymptomatic patients with primary TR and progressive RV dilatations or systolic dysfunctions, we go down on the classifications to type 2B, and same for right-sided heart failure, severe tricuspid, who had previously had left-sided heart surgery, so we're talking about redo cases. The European classifications didn't change much, and I'm not going to go over all the details, except that they added in their 2A classifications, surgery should be considered in asymptomatic or mildly symptomatic patients with isolated severe TR and RV dilatations, which are appropriate for surgery, as well as some words about transcatheter treatment in symptomatic secondary TR, which are considered inoperable. So you can go across the whole algorithm of indications. The most important things now to keep in mind would be the very left-sided of the graphs, where severe RV dysfunction, severe pulmonary hypertension are the patients which are at very high risk of surgical procedures, and we'll come back to those. There's also Japanese guidelines which, through these articles, bring further concepts into the secondary TR, where they judge the atrial functional TR, that would be the bottom one here, where not only the annulus is dilated to 40 millimeter, but those associated with persistent AF, because we all know that those patients are most likely going to have progressions in their functional tricuspid regurgitation. So, for the sake of time, I just want to show atrial fibrillation is now part of the diagram for the Japanese associations. Now, what are they based on? They have a couple of studies, mainly from Japanese literature, that look at risk factor for significant TR following their mitral valve surgery. So 3+ or more TR, the follow-up. Here in this paper, the odd ratios is 3.9. On that second paper, where preoperative atrial fibrillations at the time of left-sided surgery bring odd ratios for progressions of their tricuspid regurgitations with an odd ratio of 12.8. And that last meta-analysis shows with 5 different papers that there's no questions that preoperative atrial fibrillations bring a high risk of worsening of the tricuspid functions. Now, we know that tricuspid surgery, and that's been discussed at this session already, is quite a very risky procedure. And I would strongly favor that within the next recommendations, we would have, here I've taken the example of TriScore, which is what I use in my practice, just based on the simplicity of acquiring the informations and the very well-cut risk factors. So usually, if the if the TriScore is above 4, I would think twice of bringing those patients to the OR. And these data have showed us that if you're in the low TriScore risk, you would have a great survival and quite a low perioperative mortalities. But as you get into the intermediate risk, it becomes less favorable. And when they try to dissociate repair versus replacement, they also find that like in the intermediate group, there would be benefit for repair, but maybe not as much for a replacement. And if you push the idea of what about the transcatheter procedures, well, these seems to be, at first view, less favorable than was the surgery in the low TriScore groups. But then again, they differentiate what you would have in terms of benefit of survival if you have a successful percutaneous procedures versus unsuccessful. So I think that we should have not necessarily the TriScore itself, but we should have one of the risk evaluation tools as being guiding our therapy. Now, coming back to the transcutaneous procedures, which have not had any real space in the recommendations so far, I've just taken this recent paper that's looking at in-hospital admissions for people having tricuspid procedures. And obviously, the percutaneous and the open surgical approach had not exactly the same patients, with more morbidities, more congestive heart failure, more diabetes, more hypertension. They were a bit older, but their perioperative or peri-procedural mortalities were quite lower. The cost of those therapies were quite lower, and the whole spectrum of perioperative morbidities has been quite lower. So that needs to be taken into considerations, coming back with new recommendations. This article is here reviewing the Tricuspid Valve Academy Research Consortium definitions of TR, also bring interesting windows about what to do with the guidelines, especially the orange box on the left. There's continuous risk mortality associated with increasing severity of TR. We know that TR is a progressive disease. Surgical results tends to become unfavorable as that right failure progresses. The yellow box guidelines recommendations for surgical management have poor penetrations, even though we went and listed the whole features of the present recommendations. Very often I meet groups where they would not be as aggressive as the guideline shows, especially with secondary TR. And So we should put into our algorithm some transcutaneous therapy, given the fact that here, just few examples that the mortalities are so low, but the results also needs to be standardized and better defined. And just for the interest of time, I might just switch to the very last elements that I wanted to bring in. We have discussed pacemaker leads, and also in Montreal, we would not leave any pacemaker leads in place, but that should probably be also part of guidelines of what do we do with leads. When is it valuable to take it out and take a risk of removing a leads and putting leadless pacemakers? When is it that just pushing it again a ring, something that we have not been doing in the last couple of years, would be the best things to do, but that also might require some guidelines. So in conclusion, first of all, I think that there's not super solid evidence, but it is present enough that atrial fibrillations and atrial functional TR is part of the mechanisms of the progressions of TR, and that should probably be considered to be in the guidelines. The percutaneous therapies, either edge-to-edge or transcutaneous tricuspid valve replacement, need to have a place. Now, these are the future, a bit like was being said by Gaurav in the previous presentations, of the tricuspid therapies. Perioperative mortalities and morbidity are just too important in the tricuspid world not to have a form of risk stratifications within our recommendation. And a bit more as a secondary role, I think that pacemaker lead management should have a form of recommendations, because removal of the leads might lead to dangerous complications, and leaving them alone might be not satisfactory in terms of lead function. So thank you very much for your time.
Thanks very much for this interesting presentation. And actually, we are now seeing more and more cases of percutaneous options for tricuspid valve, so I do agree with you. But I have a comment or questions about the subgroup of patients who are asymptomatic and they do have some sort of RV dysfunction or pulmonary hypertension. So what do you think about those subgroup of patients in terms of the guidelines and decision making?
Yeah. I think that if they're asymptomatic and there's signs that there's RV progressions, and I don't know which one of the echo tools that we have been discussing before in these sessions can help us tease out those at high risk of progressing and being candidates in a better window for therapy, but there would definitely be some asymptomatic where I would consider for surgery, especially if I can tell that they're about to turn around in the wrong direction.
Thank you very much. Any questions from the?
Thank you.
Thank you.
All right, I think our last speaker's Ahmed. He's going to talk to us about how do we perform tricuspid valve repair with low morbidity, particularly pacemaker rate.
Thanks a lot, Gaurav. Yeah, so it's an honor and privilege for me to present for the society here in Egypt. And thanks everyone for waiting until the last presentation. I'll try to make it as quick and simple as possible so we can all go home. How to minimize the risk of pacemaker? We know every time you do tricuspid annuloplasty, you're putting the patient at risk for a permanent pacemaker, and that in its own, has its associated mortality and morbidity. So this is our protocol at Mount Sinai. As you know, we are one of the most aggressive centers in doing prophylactic tricuspid repair at the time of left-sided disease, particularly mitral repair, for a variety of reasons. We repair any moderate or severe TR, but more important, we repair any patient who have even mild tricuspid regurgitation or no tricuspid dilatation with risk factors. which is as Dreyfus recommended, annual dilation more than 40 millimeter, or other, RV dysfunction, dilation, pulmonary hypertension, even atrial fibrillation. I agree 100% with the previous speaker. So I guess we were implementing the Japanese guidelines at Mount Sinai without knowing that, because definitely AFib will have progression of disease. And we proved that by doing this, we're protecting this patient on the long term from moderate or more TR. And more important, we preserve and recover the RV function on these patients, because remember, the tricuspid regurgitation doesn't disappear after doing the left-sided disease. A lot of these patients will have progression of disease. So how we do tricuspid annuloplasty? So the ring we use at Mount Sinai is a unique ring because it's called a triad 2 ring. It has a rigid component toward the right ventricular free wall, because we know that's where annular dilation happens. But then you don't need to have any rigid component of the ring toward the membranous septum, because that's the mobile part of the annulus. And that's basically to minimize the risk of dehiscence and also heart block. We're all aware of the triangle of Koch. We have to be very careful. The AV node can sometimes be at the apex, most probably, but sometimes it moves more, proximally toward the coronary sinus. So basically, you have to visualize the AV node and try to avoid it. And also, you have to even take the sutures a little bit further away. So this is, in general, you start from 6 to 9 o'clock. No suture should be placed in between these two ends of the ring, because that's when you increase the risk of heart block due to the destruction of the AV node and the bundle of Hess. That's a surgical video from our library. You can see the coronary sinus catheter. This is the AV node. You can see, sometimes this node is bilobed. It has a AV nodal artery. Sometimes you have to be careful about injuring the vessel. You should never get close to any yellow structures in this area while putting the annuloplasty sutures. So we size the ring based on the anterior as well as the posterior leaflet, and then we measure the surface area. We don't undersize these valves. You need to just true size these valves, because as I said, it's a prophylactic surgery. So this was a size 30. We do all these cases universally on arrested heart. We don't do beating heart surgery when you do concomitant, because you need to see everything and you want to avoid tears and dehiscence and injury to the conduction system, etc. We start always by putting the 6 o'clock suture, because this is the most important suture. We put this suture first, the 6 o'clock, so you know you're not going to go beyond. And then we put the 9 o'clock or 11 o'clock or 10 o'clock. That depends on how big is the aortic root, because you don't want to put suture near the aortic sinuses. The sutures has to be good sutures. This suture is a cross suture. That's not intention, but we don't mind interlocking the sutures in tricuspid, because we think this will actually augment the annuloplasty and make it more stabilized. Avoid taking superficial suture or flimsy bites, because that can tear and cause leaflet injuries and dehiscence and things like that. And you always have to direct the tip of the needle toward the inside toward the ventricle or the atrium, because you want to stay away from the right coronary, which is also another disaster that can happen with prophylactic tricuspid repair, especially as a lot of our patients, 60% of our patients have no symptoms. So the patient doesn't want to come out of the OR with a pacemaker or another thing unrelated to his mitral disease. This is a sealant test. You can see already the annuloplasty suture have created some annuloplasty effect. So this marking, just to show you that the rigid component of the ring is really limited to the free wall of the right ventricle. And this is very important, because we don't want to use a complete rigid ring. Otherwise, that risk will go up. This is a flexible end, so this ring has a 3-dimensional motion as the heart moves. So you have rigid component where you need the remodeling to happen, and you have flexible components where you want to avoid, injuring structures around, because that part of the septum or the membranous septum is very vulnerable to injuries and tears, etc. So that's how it looks. That's a perfect tricuspid repair. We do it, as I said, on arrested heart. You can do it before or after the mitral, it doesn't matter about. Okay, so we'll move on. This is just an example of a patient who had a Barlow's valve. Again, for the sake of time, we'll just keep going. I'll show you the video. You can see some of these patients, they have big Barlow's valves. I mean, you're gonna fix the mitral valve, but look at the tricuspid. It's almost like a Barlow's tricuspid valve. Exist tissue, myxomatous disease, multiple jets. No question we're gonna repair the tricuspid valve, right? We don't even look for the annular measurements or anything. We already have got the indication. That's how this valve looked. You see, massive valve. You have to be careful with undersizing because one of the mechanisms of injuring the right coronary is aggressive undersizing of the ring. This is the largest size we have, but still, you see, it's a 34 triad band. But you're not going to have a normal tricuspid annulus even by putting that band. We definitely, sometimes you need to add adjunctive procedures. Like here, you can see some leak between the septal and the anterior leaflet. So we use adjunctive tools like commissuroplasty sutures between the anterior and the septal leaflet. That's the most common site where we put annuloplasty suture. And I think that's what they do also in clipping the tricuspid valve most of the time. That's not going to create any dysfunction or tricuspid stenosis. Those valves are massive. And you see the final echo result, very good tricuspid repair. This is what you should never do. You see the surgeon already, this is a redo case, almost put the ring across the AV node. Of course, the patient needed a pacemaker. So you're doing a tricuspid repair to prevent tricuspid regurgitation or to fix tricuspid regurgitation. Then you give the patient a complete heart block with a transvenous pacing, which will bring back this tricuspid regurgitation. And then you inherit all the complication of a permanent pacing. We redid the tricuspid annuloplasty, and you can see that gap, the difference between the triad and the original ring. There is many ways to manage the leads. You can put it in a commissure, or you can exclude it, or you can take out the leads and use epicardial pacing or transvenous pacing, or leadless pacemaker. This is another patient who had status post-renal transplant. The patient presented with severe primary TR. Look at the tricuspid valve, restricted valve, torrential TR, eccentric jet. So for isolated tricuspid, sometimes you can do it on beating heart or arrested heart, depends on the RV function and the comfort of the surgeon and things like that. I'm just showing this video to show that we use leadless pacemaker at Mount Sinai a lot because, as the previous speaker said, you should never pass any wires across a repaired tricuspid valve because now you're jeopardizing the long-term durability of the repair. Now they have pacemaker, leadless pacemaker, it have even AV synchrony feature. So there is a lot of progress and movement in the technology for the leadless pacemaker to avoid the pacemaker-related complications. As we know, the patient will have endocarditis, risk of thrombosis and valve dysfunction and cardiomyopathy, etc. So we have published almost the biggest series in the world on a leadless pacemaker, and we proved that it's actually safe and efficient, and it has its financial incentive. Finally, I'm just going to end by this case. Some occasion we do a beating heart, isolated tricuspid with bad right ventricle. I think you can safely do beating heart surgery. As Gaurav said, you can monitor the conduction system, the ischemia, everything. Every time I do beating heart, I have to vent the left side. I really ask the anesthesiologist, the patient had an ASD or shunt, but doesn't matter. The patient can still shunt air right to left through the pulmonary circulation, so I vent the root all these cases. This is the final look of that valve. Again, we use the same ring, triad, and then you kind of get an immediate feedback about the competence of the valve on beating heart. So that slide will conclude my talk. Just remember that clock. Don't put suture between 6 and 9 o'clock. Thank you so much.
Any comments about that? I think it's important for all of us to know what our outcomes are for pacemaker, and I think the Mount Sinai group has nicely reported their outcomes and really set a high bar. We actually looked at ours, and we're seeing very similar results, particularly if we stratify patients by surgeon who is a mitral tricuspid focused surgeon versus the general cardiac surgeon. We're actually seeing that difference as well. So I think it's very important. And I agree with you, and I'll even go as far to avoid even 6 o'clock and maybe closer to 5 or 5:30, just to really avoid. In the triad, we've moved to exclusively to try to minimize that risk. And I personally agree with you, avoid downsizing too much, particularly if you're doing it for prophylaxis. There's really no need for that. So I think that's a very important point for us to consider.
Yeah, I think you always stay away from like lateral to the coronary sinus, you'll be safe. A lot of the pacemaker are all technical, I believe it. I mean, some patients, they have high risk for pacemaker. Patient had ablations, other surgeries, patients have preoperative conduction defect. We know that this patient can get permanent pacemaker after tricuspid surgery, that's not necessarily related to the tricuspid surgery itself, but it could be because of patient-related factors. And those patients, if we anticipate this is going to happen, we have to do the alternative pacing strategy. So I either put a leadless pacemaker or I put the epicardial leads, and then I leave it. If the patient needs a pacemaker, the electrophysiologist will connect it, so we haven't lost anything.
So I was struck that you actually deployed the leadless yourself, which I haven't done. It would allow us to do it through less invasive approaches without having to do epicardial leads. How often have you done it? Any concerns, any tricks?
We have done over 100 patients, so we have really got interested. Leadless intraoperative implantation. It takes exactly like a few seconds. I guess Percy can comment on that because we have done a lot of these cases together.
Yeah, I think just to slight clarification, we call the EP guy into the room, we give him the exposure, and then he does the deployment. I mean, we could do it, but there's just a collaborative team thing, and he enjoys doing it. He comes to the OR, gets a little bit of surgical exposure.
He deployed the device, but we deliver it in the right way. He doesn't touch the heart.
We hold it for him to deploy.
How do you don't test it then when you're doing it on a rest start, you have to wait till you're off pump.
Exactly.
Yeah. But if you're beating, could they test
And,
it?
and once you have it, Gaurav, we don't put wires. We use a leadless pacemaker,
What about the patients who had the tricuspid valve injured after removal of the pacemaker leads? What's your strategy for such patients?
Well, any patient who comes with severe TR with a pacemaker lead, we almost never do them until the electrophysiologist tell us if he can take out the leads or not. Most of the time, if these leads has been on for too long, what happens is you have retraction of the leaflet, fibrosis, and then it becomes very difficult. And many times you injure actually the leaflet, as Gaurav told us, and then you have a flail valve. I would say almost all these patients will come to you for surgery. So what you do, we take out all the transvenous system, we repair or replace a valve, and then you pace the patient differently, epicardial or leadless.
Yeah, I think it depends on what's the underlying pathology, right? If they have a lot of restriction of their leaflets, then I think you have to replace it. In some of these patients that have AFib for a long time, they have more of a Barlow's type valve, kind of thickened leaflet. You can actually repair those valves. Again, it comes down to how much leaflet you have. And some of those strategies will actually will actually leave the leads on and use those to augment the repair by putting it on the tricuspid annuloplasty opposite the area of tethering. So we've actually augmented that.
Mainly it depends on the pathology and what's...
Great discussion.
Thank you
you
so much.
everybody, and I
Thank
guess
you
we
very
look forward to the next session. There's a poster session.